Hello and welcome to this webinar hosted by Pallium Canada. I'm Dr. José Pereira and I'm Scientific Officer of Pallium Canada and Professor and Director in the Division of Palliative Care, Department of Family Medicine at McMaster University. Today's webinar is on providing a palliative approach to care in long-term care homes during this COVID-19 pandemic. This is a sector, as we're all hearing in the news and the media, that is being particularly hard hit by the pandemic, with a lot of tragic consequences. This webinar is one webinar in a series of webinars that we've been presenting over the last few weeks, and we invite you to view the other recordings. They vary. The topics include things such as donning and doffing PPE in the home, which is very different in the hospital, reorganizing healthcare systems to provide palliative care, symptom management that includes the management of dyspnea, as well as a webinar on the impact that COVID is having on healthcare professionals, including palliative care providers. This webinar series has been funded by an unconditional education grant from Boehringer Ingelheim through its Bridging Hope initiative. We have an excellent panel today of experts whose work is in or related to the long-term care sector, and all have a special interest and expertise in providing palliative care in this sector. Before they introduce themselves, just some housekeeping. First of all, your microphones are muted. There are several hundred people actually signed on to today's webinar, so it's going to be very difficult to take that all in via voice. So we invite you to please use the Q&A function at the bottom of your screen to submit questions or comments. So if you look at the bottom, you'll see an icon that says Q&A. Please, we ask you to submit any comments or questions that you have through that one. Please do not submit it in the chat mode, rather in the Q&A icon. We'll do our best to answer and to look at all the questions and comments. One of the richness of this webinar series has been an opportunity for us to share experiences and insights across the country and even internationally. So part of this webinar is to try and collect that tacit knowledge, those experiences that exist, and share it with everyone else. The session is being recorded, and the links will be emailed to all webinar registrants. Please invite colleagues to go to the Pallium website, www.pallium.ca, and if you look at the resources, you'll see the webinars and the recordings of previous webinars. At this point, I want to hand over to Dr. Amit Arya, who will be the moderator for today's webinar.
Yeah, so welcome everyone. It's a pleasure to sort of join in this virtual community and speak about this very important topic. So my name is Amit Arya. I'm a palliative care physician working at William Wilson Health System in Brampton, Ontario, and I also have faculty appointments at McMaster University and the University of Toronto. In addition, I'm the lead for a robust consultative shared care model of palliative care in our long-term care facilities in our region. We have 23 long-term care facilities in our region. And I'm also, part of the long-term care rapid action team for COVID-19 for our hospital system. In many other places, we might be referring that, we might be referring to that colloquially as a strike team or a SWAT team. So I'm playing a major role in that as well. And long-term care and improving the quality of life of the people in long-term care is really my passion. So I invite the other panelists to introduce themselves.
Thank you. I'm Benoît. I've been in practice since the turn of the century. I've been working in long-term care since 1994, and I'm currently the medical director for the Pereira Veterans Health Center. That's a 450-bed facility, and also co-medical director for the dementia program at a different long-term care, the Glebe Center. I have a private practice and I work out of the hospital. I have added certification in care of the elderly and palliative care. And I enjoy what I do. Next.
My name is Mike MacFadden. I'm a nurse practitioner in Saskatoon. I apologize for the accent. I know there's a lot of panelists from the East. My work is exclusively in clinical management within a 100-bed long-term care facility called Samaritan Place. But I've had experiences in areas like physical medicine and rehab, as well as emergency services that really drove my passion toward palliative and hospice care.
Hi, everyone. It's Sharon Kaasalainen. I'm a professor with the School of Nursing at McMaster. Feel like I've kind of grown up in long-term care. Started early on as a volunteer in high school, and then a personal support worker, and later on as a registered nurse. So when I started my academic career, it made sense. This is where I would land. So my research program is focused on strengthening a palliative approach in long-term care. I work with a number of exceptional scientists and clinicians across the country with that program, and doing lots of work that now seems to be even more important as we see COVID and its how it's hitting long-term care homes.
Before we go, just a few other bits of housekeeping. Declaration of conflicts. Pallium Canada is a non-profit pan-Canadian organization. It generates funds through to support its operations through course registrations of its LEAP courses and sale of products like the Pallium Pad of Pocketbook. It's partially funded through a contribution by Health Canada, and over the years has received funding from Health Canada. My conflict of interest potentially is as a paid staff member of Pallium Canada as scientific officer.
So for myself, I also receive an honorarium from LEAP, from Pallium Canada for reviewing LEAP modules, and none of the other panelists and presenters have any other conflicts to declare for today. So moving on, this slide addresses some of the learning objectives for this webinar. We're firstly going to start at looking at some of the common palliative care related issues being confronted by long-term care homes during the COVID-19 pandemic. We'll discuss a basic approach and strategy to initiating advanced care planning and goals of care discussions, once again within the context of the COVID-19 pandemic. We'll have an opportunity to describe the most common symptoms and complications faced by patients with COVID-19 and describe some initial approaches to manage them. We'll talk about and review the impact of COVID-19 in long-term care facilities, not just on the residents, but their family caregivers, as well as the staff. So just a brief overview of the current situation. As José already mentioned, I mean, of course, this is in, in the national spotlight at this time, and it's really highlighting a national tragedy, to be honest, that's occurring in front of our eyes. So some initial data that we know shows that, I mean, in terms of the curve for the spread of the pandemic, in many areas, the community spread of the curve is perhaps peaking or has already peaked, and we're seeing flattening of the curve. But in congregate settings led by long-term care facilities, unfortunately, we're not seeing that. And some initial data that's been prepared from some colleagues from the University of Ottawa has shown that, the case fatality rate in long-term care homes in Canada is estimated to be about 20%, 5% higher than the global case fatality rate among people over the age of 80. As we're hearing from the public health authorities and the public health, officials in their conferences, we now know that over 50% of all COVID-19 deaths are actually in long-term care facilities, and in some provinces like Quebec, it's actually as high as 70 or 80%, and over 1,000 people have died. And this is actually from last week, and I think from what I'm hearing, as we all know, all this information is changing daily, but these numbers are now unfortunately much higher. Next slide, please. Yeah, so this slide just presents some information that we have from the pandemic about mortality and the course of COVID-19 illness. So initially from China, specifically from the Chinese Center for Disease Control, we have some information here on the left where for people that were tested, they did find that 80% of them had mild disease, meaning that they had no symptoms or mild viral pneumonia. 14% of them had severe illness, meaning that they had bilateral pneumonia and hypoxia. 5% of them developed critical illness, meaning respiratory failure, ARDS, and so on. And 80% of deaths from China were in people who were over 60 years of age. The US experience also sort of shows a slant where we know that elderly, frail individuals are most at risk for death from COVID-19 illness. So specifically in the US, as we can see, people who were over 65 years of age were responsible for 53% of ICU admissions and 80% of deaths. And looking at this from the long-term care perspective, I mean, we all know that long-term care is really for people generally who are elderly and frail with life-limiting illnesses and who have functional impairment. And that is, of course, one of the reasons why COVID-19 has hit these facilities and harmed the patients so much. So one important thing for us to start and look at is what are some of the structural issues in these long-term care facilities and who are the people that live there? So firstly, I mean, just to kind of elaborate a bit on that, we know that, I mean, this is usually people's last move when they go into a long-term care facility. And what's the reason for that? Well, generally they have moderate to advanced life-limiting illness, most commonly dementia, or a combination of other illnesses, which could include COPD, it could include heart failure, it could include renal failure, it could include cancer as well. So essentially, patients are very, very sick by the time they end up in long-term care facilities. And that really sort of speaks to the importance of the palliative care approach in these nursing homes, even before COVID, where, I mean, we know that palliative care is not just end-of-life care. Palliative care is an approach that should really start at diagnosis and is really geared towards treating suffering, supporting families, and also helping patients and families to make the best decisions for themselves moving ahead. So in spite of the need for palliative care as a core skill set and a core service, to be delivered in these long-term care facilities, unfortunately at baseline, these facilities are often under-resourced and understaffed. And ironically, although it's taken a national tragedy for us to get here, I mean, we are now as a society, and we're seeing this in the media, as a society now we're becoming more and more aware of the staffing issues and resource issues that exist in these long-term care facilities. And specifically, it's likely because COVID-19 has tipped over the balance. I mean, we know that, for example, to elaborate a little more, I mean, in many of these long-term care facilities, there may be one sort of unit with 32 patients, which are staffed by one nurse and 2 or 3 PSWs. And with COVID-19, where some of those staff may be at home isolating, or there may be staff shortages with the new regulations where staff can now no longer move from home to home, I mean, it can really tip over the balance in trying to provide appropriate care. We can see that with COVID-19, if we have, even out of those 32 patients on a unit, if we have a few patients that are quite ill and need diligent monitoring of symptoms and administration of PRN medications, that may be very hard to do if you're kind of by yourself. And as we know at night, some of these, staffing ratios drop further. So I think it's important for us to recognize this, and it's important for us to recognize how we can support this sector of the healthcare system and support the patients there, support the health workers there, not just now in a time of crisis with COVID-19, but also after the pandemic. So specifically, I mean, this webinar, I mean, of course, there are a lot of issues that that are critically important for long-term care, such as testing and, infection control and so on. But our focus will, of course, be on, on palliative care and how to best deliver palliative care during this time. And we'll sort of share experiences from the front lines, and we'll overview some of the key issues as we talked about, such as symptom management and advanced care planning and goals of care discussions. And then we'll move on to questions and answers. And once again, as José has mentioned, I'll be sort of monitoring the chat box as well to sort of hopefully give an opportunity to discuss this together. All right, so I'll hand it over to Ben, right? Now we're gonna go around as a panel and speak to some of our experiences across the country.
maybe I'll unmute myself. It'll be easier for people to hear me. 2 weeks ago, we were officially a COVID-free zone. And then a staff member developed community-acquired COVID. A few days later, a second staff member was diagnosed as positive. And now we're sitting with 11 residents who have COVID and 22 staff who have been diagnosed as well. The key thing for me to sort of mention is that with our first COVID staff member, we were able a few days later to swab the whole facility. And so by the weekend, we had everybody swabbed, so 450 people. And what struck me was that when we got the results on the Monday, 6 residents were positive and all of them were asymptomatic. They were on a secure unit for dementia care and they were all at baseline. So we cohorted them to a unit that we're calling the isolation unit. And for another 24, 36 hours, they continued to be asymptomatic. And suddenly 2 of the residents fell very, very short of breath in a matter of hours. One has died since, and the other will die shortly. In the interim, we've had another 2 residents who did not have time to be transferred to the isolation unit, who died within 24 hours of acute onset of dyspnea. So basically, what I've found is that I'm very humbled by how it spreads, and also how some people develop symptoms very, very rapidly, while the others continue to be at their baseline.
Michael?
Yeah, you know, in Saskatchewan, we've had the benefit of geography and our population's disbursement, but early on in the pandemic, our government sort of centralized operations. And so for myself, I've benefited from their expertise, and myself and my colleagues in our home are supporting our residents by ongoing goal of care conversations with people as we review medications and care plans, look at some structural and logistics planning so that we can address the evolving needs. To date, we haven't got any positive cases either of employees nor of our residents, thankfully, but we are taking measures in anticipation of that occurring.
Excellent. Sharon, can you share some of your insights?
Sure. So I'm no longer in clinical practice, but I do a lot of research working with clinicians, families and residents. So our research program is very much on the ground, and I really enjoy that part of my work. I work with a large research team. We have a grant right now with people from 6 different countries. So when we first heard about COVID, all of us essentially research programs came to a quick halt. And you know, we had a couple of meetings trying to learn from one another. So we have a medical director who is from Italy. You know, we're trying to figure out how can we best support the long-term care sector at one of our resources. So we all work together trying to find ways that we can support our colleagues who are on the front lines because our research essentially was halted. Incredibly heart-wrenching. You know, we've been working for a long time over 20 years developing a research program, and during COVID, it seemed to me, all the knowledge and tools that we developed were essentially put aside, and people were just struggling to cope and survive in this pandemic. So now we've had a bit more time to reflect, and certainly re-looking at our research and ways of improving the care for residents who are dying and their family members.
Okay, thank you for that, Sharon. I mean, since the pandemic has hit, and as I mentioned, I've been involved in providing palliative care consultations, in our long-term care facilities quite actively for some time before the pandemic. So I think that those relationships and those bridges that we had built, before the pandemic have only become stronger in our region, where I'm part of the long-term care rapid action team. And we have done a lot of work to proactively work with the long-term care facilities and other partners at our hospital, not just palliative care, but emergency medicine and geriatrics, to proactively see how we could best support the patients and the families and the health workers in these facilities. So we created a goals of care sort of guidance sheet very early on that was sent out to all the long-term care facilities. We created sort of an information sheet that was patient and family facing to speak about how it was important to have these critical conversations with their health workers and document sort of wishes and expectations around care with COVID-19, and understand, prognosis for long-term care patients, and also understand that, of course, although in the media there's a lot of talk, which is kind of changed a little bit in my opinion over the last week, but prior to that, there was a lot of talk about ventilators and sort of people being denied ventilators and causing a lot of anxiety. So we tried to address that anxiety up front and speak to how, to be very honest, most of our patients, or almost all of the patients in long-term care, would not survive, a stay in the ICU and would not benefit from that sense, from being on a ventilator. So we kind of did that proactive work. And recently we actually have a toll-free number, which any of the long-term care facilities can call, that we've worked very hard to put together. And our nurse practitioner colleagues actually answer that number and can help with sort of, supporting the health workers who are looking after the patient in the long-term care facility. And in addition, can triage to have a virtual consult happen with a palliative care specialist, geriatrics, or even speak to the emergency physician rather than transferring directly to the emergency department. And of course, we're very hopeful that these resources, which are now available to long-term care, which to be honest have probably always been something that have been helpful, will sort of continue now, but also beyond the pandemic.
So whether you're part of a task force or a clinician like myself, there's a number of universal themes and challenges that we're all being confronted with right now. Whether it's our lack of preparedness to deal with the large scale of morbidity and mortality due to the pandemic itself. But there's also this challenge we've got in promptly addressing goals of care and advanced care plans for those whom we are looking after. There are rapidly evolving symptoms of dyspnea, delirium, and agitation, which we need to have clear guidelines, care plans, and materials to treat. In addition to increased need for an awareness of palliative sedation for end-of-life situations. There is also some apprehension and fear regarding palliative care medication shortages. So we've all worked in different ways to try to devise some contingency plans to ensure a supply. And additionally, we're looking at some challenge with respect to the impact on residents and families, in that we've had to restrict visitors, which has amplified grief. We're dealing with some distress and having residents dying alone apart from families, and a lot of guilt in experience both by the families and as care providers. And staff are being significantly affected by this, and we'll talk about that a little bit more. So I want to talk a little bit about the palliative approach itself. This is something that I've got a lot of passion about in my work. In my work, prior work in acute care, I hear statements all too often from families like, you know, Dad's strong, he's going to pull through this, when we as care providers internally have a different viewpoint. You know, just last week, I had a medical colleague who asked me to please stop having the death talk when I reviewed the palliative approach to care with a family whose loved one was in their last season of life. Without starting this dialogue sensitively and early, we are doing them a disservice. Death and dying does make us uncomfortable. It does create unease for patients and families, and even for many care providers, to contemplate the inevitabilities of death. Our health system performs so well that many people haven't considered common illnesses like COPD or dementia, that they themselves are life-limiting illnesses. When the trajectory and consequences of aging and chronic disease are not addressed, inappropriate treatment and psychological distress impact residents and their families. A palliative approach to care is not merely the care intended to manage symptoms in the last days of life. It's essential to integrate when a person is diagnosed with a life-limiting illness. A palliative approach to care does not connotate merely discontinuing treatments. In fact, it can involve a greater intensity of care, but with a different objective as we extend our focus onto the person and their family, as opposed to merely their pathology. The objective in defining a palliative approach to care is to anticipate and manage symptoms to assure the best possible day for each day of life, as it would be defined by the patient. And lack of clarity about the goals of care can lead to miscommunication and inappropriate interventions, both of which can contribute to distress for the patient.
Yeah, so speaking to the importance of advanced care planning and goals of care discussions, I mean, as we've alluded to, and as Michael has just mentioned, it's critically important to have these conversations. To be honest, it's very important for all of us to have an advanced care plan in place, whether we're sick or not. But for the residents in long-term care who are already quite ill and really in the last months to years of their life, I mean, you know, having these conversations and having them early, having them regularly is so important. And also, I would add, we need to have it well. And an additional challenge right now is that we need to have it often, perhaps with the family over the phone rather than face-to-face sort of conferences. And we need to have it in the context of the pandemic. So we can only imagine sort of some of the stresses that are going on with these conversations. I would like to share a little bit, you know, colloquially, how I felt with the consultation service that I provide in these homes, that having these conversations has become more hard due to these factors. I mean, recently I was speaking to, you know, a family member, and they really sort of weren't aware of their loved one's clinical situation, which was changing in the facility. And in addition, they sort of told me up front that they didn't really believe me because they were hearing sort of an alternate narrative in the media. You know, with respect to how ventilation could be denied to people because they were old, or possibly in a triage situation, even though no such situation exists, you know, where I work. So, I mean, I think this is, I mean, this raises, you know, some discussion about some of the unique challenges about discussing, you know, goals of care, which was, you know, perhaps, you know, something that already need to be strengthened up before COVID, but now has become even more challenging. So, Ben, you know, can I ask you to share some insights that you might be having in your work and in your facility right now?
Yeah, so basically, we're fortunate in that we've been using goals of care conversations early, and many of my colleagues have training and certification in palliative care. So that's been very, very useful. We have here at the Pereira a standardized template, if you will, that we call CME, and most of our care conferences are based on frailty-informed care. So a lot of the family members, a lot of the residents as well, already know what the possible impacts of treatment and impacts of no treatment can be. And so for us, it's just been a matter of revisiting the changes with COVID and it's gone quite smoothly. At the same time, we are suddenly giving families and residents, primarily from what they've seen on TV, what seems to be a death sentence, which is certainly not the case. When you look at the numbers, right, 70–80% of people in this age group actually survive COVID. But what we see on TV and what we hear on TV certainly doesn't seem to be that way.
Yeah, so that's some excellent insights, right? You know, Michael, have you experienced some additional challenges at this time with the pandemic and sort of having these conversations with your patients?
Yeah, no question. It's been especially difficult to try to have these dialogues when you don't have that person right in front of you. I think for myself, hasn't been a lot of good news stories about long-term care. It's been many years, and now there's a lot of negative attention that's being spent. So people have that much more apprehension about our capacities, abilities, and commitments in the care that we're providing to their loved ones.
Yeah, excellent. Yeah, it's a really challenging time for everyone, and I think there's a lot of distress and anxiety around the world, and specifically, I mean, you know, with caregivers being separated from their loved ones, or like the family caregivers, sorry, being separated from their loved ones, has created, you know, like a very different situation that many of us are not used to when we provide the palliative approach to care. It's actually the opposite of what we generally do. So if we can go on to the next slide, please. So yeah, this slide, I mean, we wanted to provide you with some initial guidance and some approaches to how you could discuss goals of care at this time in the long-term care facility with COVID-19. So one approach is based on the 3 W's, so wish, worry, and wonder. And I think that these are very good phrases to use where, I mean, we could say that I wish we were in a different time, but of course this is, you know, like we have a COVID-19 pandemic going on, and, you know, I wish that, you know, this wasn't the case, but unfortunately people that are older and weak and have multiple comorbidities are the ones that are being most affected. You know, the second W looks at worry. So I worry that, you know, if your loved one gets this illness, it could be very serious, and therefore it's very important to plan ahead and make sure that that they get the best care available with the resources that we have, and making sure that we understand for residents what's the most important for them at end of life is very important. I mean, it's always been important, once again, because these patients generally are already quite sick, but it's even more important during the COVID-19 pandemic. And then we can always share in the hopes and values and beliefs of our patients whenever possible. So we can say, well, okay, I hope that you don't get the infection, and I wonder if there's things that are priorities for you at this time that we can help for you to prepare for, you know, in this context. On this slide, we just wanted to share some actual wording that you can use. You know, this will all be provided, you know, after this sort of, you know, talk on the slide. So you don't have to write it down or anything right now, but these are just actually some wordage that we used at our site and provided to all the long-term care facilities. So just sort of reading through some of these, you know, based on our review of your loved one's clinical status, we are worried that this coronavirus, along with their previous medical conditions, is leading to an end-of-life process. In the second sort of phrase, I mean, there's this sort of few words here, which I really like using, where we say sick enough to die. And I think that's very important because it brings up a point that Ben, you know, brought up earlier, where there's a lot of uncertainty in many of these situations. Even if we see a patient that might become a little short of breath or might become hypoxic, we often may not know what might happen because the mortality is not 100%. The mortality rate, as far as we know, and this data is all changing as we collect, you know, more and more information, is around 20%. So there may be patients that could recover, and those patients still need a palliative approach. So I really like this phrase, sick enough to die, because it gives you that flexibility as a health worker where, I mean, if they do pass away, well, then you made sure that, you know, like the family was aware and they could, you know, perhaps in this environment, they could Skype with all their loved ones in and they could all console each other and be ready for it. And if you didn't use it and if you used it and they recovered, well, that's fine too, right? Where, I mean, I think we can all be happy about that. So, I mean, this is once again just some phrases that we could use, you know, at this time. And I think it's very important for us to acknowledge that, I mean, we're always going to, you know, like we're always going to try to provide the best care that is available for us with the resources that we have. And, you know, palliative care is the best care in many situations. So Ben, if you can sort of speak a little bit about symptom management, that would be great.
Sorry, I've been listening. It's really good. I'm learning lots.
I think we all are. Thank you.
Yeah. So basically, the rules of thumb are there, and all I can emphasize is that the person's condition can change very rapidly, and so as a result, the titration of medications to control symptoms is probably faster than what we're accustomed to. And so with that in mind, then you need frequent monitoring, and it doesn't have to be the whole assessment, but it does need to be good enough that you get a sense, or the staff get a sense of how the person is. I've been surprised by how well the people with dementia are tolerating the subcutaneous needles. Not most of them, not all. And the other thing as well is just to make sure that the medications are available. In our facility, we do have an isolation unit where people with COVID positive test results are being cohorted to. And, you know, with that, I use 30% mortality, but I mean, with that mortality rate, I've asked that the unit always have at least that number of medications available in contingency, so that we know that 30% of the unit at any given time may get sick quickly, so that the staff now don't have to be running, looking for medications, particularly in the nighttime. Oxygen needs to be available, we require it. Realize that I would emphasize no fans for the dyspnea, as it might aerosolize some of the virus. So when it comes to dyspnea, remember that in this case, because things are happening quickly, I would recommend using the opioids first. Okay, so low dose, but frequent reassessments. The dosing we're using here is, we use Dilaudid or hydromorphone, 0.25 milligrams subcutaneous every 1 hour as needed. The staff is well trained, so I trust the staff. And this is based on the fact that it took us close to 4 hours to control the dyspnea in 2 of our residents. So we were playing catch up right at the beginning. Oxygen is very useful because it's handy. Once you have the machine there, you can just crank it up. But on our pre-printed order set, we've added that if a person requires more than 3 to 5 liters of oxygen, to consider to start using the medication, the opioids, for dyspnea. And again, for people with who have a baseline CPAP or BiPAP machine, so for chronic conditions, at that point you do need the proper PPE. Those 2 machines will aerosolize the virus. With the delirium, we've been lucky, but in that we've been able to control it easily. At the same time, I presume that with particularly in people with dementia, where terminal delirium is quite common, I would probably recommend an earlier and aggressive treatment. In this case, for moderate to severe delirium, just remember that the non-medical approaches don't work as well. I'm a big fan of Nozanan. There's Midazolam. And of course, the one that's been tested all along has been Haldol. Again, low dose, but remember to titrate upwards quickly. The main, I mean, I find what's really nice is that the staff are well trained, so the PRNs are used appropriately, and oftentimes you get recommendations to get it as a straight dosing once we sort of set a baseline from the resident's perspective. So in the context of approaching in long-term care, there's a variety of things, but keep in mind that things move quickly. And people do have other underlying diseases. So they have diabetes, they have heart disease, lung disease. The dementia has behaviors that frequently the staff know well. So if you are cohorting to an isolation unit, as we are, we were lucky that most of the residents came from one unit. And so we were able to have some of the staff from that same unit come over who already knew the residents. At the same time, once you have COVID in the home, hopefully the plans that you've made onto how to cohort residents, how to cohort staff, or even cohort whole units. So right now, our isolation unit, people don and doff the PPE once they enter. And as a result, they don't have to keep donning and doffing with each resident care because the droplet precautions are the same for every resident. Of course, that would be different if we had somebody with different precautions and we'd have to doff and don for that person's care. The thing as well is the asymptomatic spread. I'm humbled. That's all I can say. The people who are in the isolation unit, they are still asymptomatic. They are still at their baseline, well, except for the one that is dying. And so then, that is, to start testing for symptomatic people, you'll always be playing catch up. So if you have the opportunity to test proactively, I would certainly use it. And then lastly, just to make sure that there are some plans for staff shortages and that management and staff feel relatively comfortable with decisions being made one day and different decisions being made the next. Because you have to go with the flow, if you will. And this is one of the things that really people who look for perfect won't find it. Time essentially is of the essence in these cases.
Yeah. I just wanted to add one point. That's excellent, Ben. Thank you for sharing your on the ground insights. You're really doing some excellent work there that we can all be inspired by. But I just wanted to emphasize that it's very important for all of us working on the front lines in long-term care facilities, to be comfortable with prescribing and administering opioid medications for breathlessness, which will really be the mainstay of the treatment for many of these patients. So we have a lot of fears about use of opioids, and we know, as just to reaffirm the point that Ben already made, that low dose symptom titrated opioids are absolutely safe in patients with respiratory failure. They do not hasten death. They do not worsen respiratory mechanics, but rather they improve sort of hypercapnia. And of course, we all have a right to not suffer, and breathing is necessary for life, but shortness of breath or respiratory distress is not. So moving on, I mean, this slide sort of offers some general sort of information about symptom management. I mean, in many areas across the country, they do have some general symptom management guidelines now available for COVID-19. So for example, the Fraser Health guidelines are excellent. UBC Palliative Care has one. The Division of Palliative Care at McMaster University has one. In many places and healthcare settings where we're on the front lines, such as long-term care facilities, they have often developed sort of a pre-printed order set, which can be used to sort of, manage these situations. An important sort of dialogue that's evolving, that obviously will vary from jurisdiction to jurisdiction, province to province, is ensuring that we have sufficient supplies of medication in order to manage these symptoms on the front lines. So we encourage you all to make sure that you're in touch with your pharmacists if you're not already doing so, from week to week, or perhaps even several times a week, and so on, to make sure that you have the right medications available, and see if, for example, one choice such as hydromorphone is not available, you could switch to something else like morphine. And some of this information, just so you all know, is in further detail on the Pallium COVID-19 online module, which at this current time is available without charge. Another thing that we want you to know is that, of course, I mean, it should have always been the case, but we're seeing it across the country that, you know, many people who maybe worked in hospitals or different healthcare settings and did not go into long-term care are now stepping up and realizing, you know, the magnitude of this crisis. And that includes palliative care physicians. I'm seeing this across the country with my specialist palliative care physicians, that they really want to now go into long-term care facilities, be available virtually or via the phone. And I hope that that's happening in your you know, setting of work as well. And we encourage you to build those bridges, not just for now, but of course after the pandemic as well. So yeah, this slide is just an example of one of the COVID-19 symptom management protocols from McMaster University. And as we mentioned, you know, this can be sort of found, you know, quite readily on the Pallium website, and there's several others available as well. Yeah, so Mike, can you speak a little bit about sort of some of these concerns?
Yeah, Sharon, hopefully everyone can hear me. Sorry if I'm cutting out. I just wanted to state, you know, what I guess I'm most worried about from the after effects from COVID is the impact that this is having on our families and residents. You know, every night I listen to the news and I hear, you know, the death rates that just seem to be piling up, and long-term care getting hit the hardest. But I worry about, you know, we know there's lots of people dying in long-term care, but what's the quality of those deaths? And we don't hear about that as much.
Oh, I think there was an internet issue, but maybe I'll just pick up from where Sharon was speaking, and then when she comes back, then I'll hand over back to her. But yeah, I mean, I absolutely echo, I'm sure what a lot of us are feeling who work in this sector or are involved in the sector, or just watching the news, that we're seeing these heart-wrenching stories of people waving to their loved ones through the window, sort of just being almost, you know, like you have a perception that many of these loved ones are unfortunately sealed off and can't get out. And, you know, as the pandemic stretches, you know, from weeks to months, I mean, we know that social isolation will have a huge impact on these residents. Where if their family, you know, if their family caregivers cannot visit, I think there's going to be, you know, irreversible harm to the residents and likely the families if, you know, there's an adverse outcome. I think we have to be ready to deal with grief and, you know, trauma and, you know, so on in this situation as well. You know, one thing I just wanted to sort of say is that, you know, and this is just from my own practice, and I'm sure, you know, from what all of you know, we know that families are not just visitors. In long-term care facilities, you know, in the role that I play, I regularly could sort of go in and meet with the families, and I see with my own eyes. I mean, you know, sort of like the children are there every mealtime, and they're feeding, you know, their parent for, you know, and they're actually sitting there for an hour or 90 minutes each time, you know, with specially prepared culture-specific food. They're actually coming in and they're assisting with personal care. They're taking their loved one, you know, to the bathroom and helping them to change. They're helping with dressing changes. They're helping their, you know, like their loved one to turn. So actually, from what we often see, and this is unfortunately part of the challenge at this time. I mean, there's this issue of grief and trauma and separation and the effects of social isolation, but also there's a loss of an essential part of the care team, which is actually the family caregivers. And when we have facilities that are already sort of maybe barely staffed in good times, and now we're losing those staff because many of them have to isolate because of COVID-19, and we've lost the family caregivers. This really presents some unique and very, you know, sort of challenging circumstances, you know, for all of us. And depending on the setting and where we work, and this has been raised in the question box too. I mean, in some settings, things have gotten so dire that we've had to move residents out of the long-term care facility, and perhaps, you know, have had to hospitalize them, or have even had to create a unique setting such as a tent or so on, where people can go and actually receive care. So do you have any comments about that, Mike?
Yeah, just moving, if we move into this slide here, this is related. I think consequences to residents have been tremendous, and it is heart-wrenching. COVID-19 not only causes a potential serious illness in those that are infected, but it has extensive implications for others in the home. An infection control emphasis disrupts the priorities of social, recreational, and spiritual care connection, which are important to holistic values for all people and really essential to palliative service. These unmet needs are often a trigger for responsive behaviors for people with cognitive impairment. And dementia being a primary diagnosis for a vast proportion of people in long-term care, as it progresses, it impacts all aspects of a person's life. Importantly, it impedes a person's present time understanding and communication, yet it doesn't negate their personal goals and values, which can create a sense of hopelessness and despair. As a resident described to me just yesterday when she wasn't able to be with her family on her birthday. The use of PPE, particularly continuous mask use, has depersonalized our connection with our residents. Those with hearing loss or receptive aphasia are unable to read our lips or interpret our nonverbal expressions as they did previously. And this only exacerbates a sense of personal isolation. Further, the physical isolation necessitated by an outbreak in long-term care increases risks for loneliness, reduced hydration and nutrition, falls, pressure injury, and responsive behaviors. And it's especially challenging to try to isolate an ill ambulatory person when they have no conception of why they need to be isolated, which poses increased risk for co-residents and staff. Those of us working in these environments experience moral distress even prior to the arrival of this epidemic or pandemic. And now we are tasked with doing even more. If we could go to the next slide, please. So as care providers in long-term care, we're challenged with a dramatically increased workload to prevent and contain outbreaks with even lesser resources, presently due to staff illnesses or absences resulting from the necessity to restrict our work to one facility. We experience moral distress at our inability to do what we want or need to do to support our residents to maintain connections, like even playing cards or sharing stories and laughter with our residents during this crisis, which so many of them do not understand. This is made even more challenging when one considers the considerable public scrutiny amplified by this pandemic about our inadequacies. And yet the vast proportion of care providers who work in long-term care are compassionate, dedicated, and committed to provide the best possible care. Just last week, I had a colleague across the table describe that she couldn't hear my words because she couldn't see my face behind my mask. Continuous mask use and even virtual consults impact our collective communication by depersonalizing our interactions and increasing risk for misunderstanding and hostility, even amongst care providers.
Sharon, are you back?
Sure. Yep. So thank you, everyone, for accommodating. Sorry, I lost connection there for a little while. So just to carry on, I think, you know, certainly lots of impacts on different people in the healthcare system and the impact on staff, you know, is another one of my big worries, given, you know, some of the moral distress we're seeing, as Mike mentioned. And there's not a lot of supports for them. Some of the, you know, I think, you know, the whole piece around their own fears about COVID and the lack of appropriate PPE for them, although we're starting to see that improving, thank goodness. And the other piece, you know, I often hear, unfortunately, you know, the staff seem to be the ones that get blamed for a lot of the kind of negative comments that we're hearing. But in a real quality improvement philosophy, you know, we wouldn't be blaming individuals. So what is it going on in the system? What kinds of processes, you know, could be improved? And I think, you know, I really feel for the long-term care staff and the homes themselves, given they can barely manage day-to-day care with the staff that they have. It was interesting talking to some of my acute care colleagues you know, they've been planning kind of preparedness for COVID for a couple of months in their staffing. So at any one time, their staffing levels only use 1/3 of their current staff under the mindset that, you know, the other staff will likely be sick. So it just kind of makes me laugh when I think about long-term care, because you can, you know, long-term care, we barely manage the staffing with the current staff that we have just to, you know, manage day-to-day staffing. So clearly, you know, it's, you know, we're going to have a huge impact. I think we all saw this coming. And the other worry for me is really, and I was talking to a colleague in Scotland who is in the middle of a COVID outbreak right now, and said in the last couple of weeks, they've had 10 deaths in their long-term care home, and it's less than 100-bed home. So, you know, that's really quite concerning. But she did say, you know, the deaths were good deaths, but the staff are really struggling. So the next slide, actually, if we want to move to that one, speaks to a way to help support staff. So this is something that we've been working on in our program, and certainly Jo Hockley, who's in the video, and the colleague that I was speaking of, she's developed what she calls a reflective debriefing exercise. So essentially, you know, getting staff to talk about their own grief and their own self-care, because, you know, given they're probably barely sleeping these days, but I think it's important that we acknowledge their own grief and seeing all of these deaths that for them, you know, have become like family. So this is the piece I feel like we may see more lingering effects, and I really worry after COVID, you know, some of the harmful things on staff, and I hope, you know, I hope it brings things to the forefront. Certainly, you know, when you think 18 months of COVID, which is, you know, what we're hearing for a vaccine, given the stats right now with resident deaths, you know, the average length of stay is 18 months. So, you know, the resident deaths, as I think we all agree, isn't surprising. It is for the short term. There's a lot more that we're seeing, but I think the after effects of, you know, the lack of support and the profound effects this will have on staff, we'll be seeing for a while. So this is a reflective debriefing, and there's some questions there. Jo in Scotland says she's holding these sessions once a day for staff, and they really appreciate it. So I think it's important we don't forget about the staff, and, you know, we're all trying to do our best, and it's really a time to come together as a team and try to support one another.
I think that's a great point, Sharon. Thank you so much for bringing that up. And I think that, I mean, we are seeing some talk that, you know, after this curve passes, or after this peak passes, we're going to see another peak of grief, trauma, and, you know, dealing with loss in health workers as well as family members. So, I mean, one of the silver linings of this pandemic, of course, is that, you know, we have these webinars, and, you know, we're seeing from, you know, across the country in many different places that there's so much interest in working together to share insights and build knowledge together on palliative care. So, I mean, this is really, you know, an amazing experience, and we actually hope that this will be, you know, an important avenue to share these insights for the pandemic and beyond. So, if everyone's okay, I mean, we're kind of close to time, but if everyone's okay and we can extend it by a few minutes, maybe I just wanted to share some questions that I found insightful. I'm so sorry, we've had a lot of interesting questions and a lot of very important questions, but I thought that there'd be a few questions that I think would be very helpful to ask some of our panelists. So I hope you're all okay with staying for a little bit. So one question that was asked, and this was specifically posed by, you know, Carrie Bernard, was that we are seeing in many different places that, you know, the importance of having family and friends, you know, present when a patient is close to dying. So do you feel that there should be more advocacy regarding ensuring that family members can safely be present when their loved ones are dying in long-term care? And I'm assuming that Carrie is speaking, of course, dying of COVID-19 illness. So Ben, I'd be interested to hear your insights around that.
So the shorter answer is yes, of course. It'd be great to have family. The The longer answer is this will probably happen when we have more people who've been exposed, when we know more about COVID. The droplet precautions are similar as with influenza, similar as with any type of pneumonia. And so we know how to deal with those. So it's not the precautions that are the issue. It's the fact that because nobody in the community has been exposed to COVID, here in Ontario, we've been able to flatten the curve so that we don't have the same pictures as they have in Italy, Spain, New York City. And if the elderly are asymptomatic and the young are asymptomatic, I worry that if we provide this type of compassionate care early, which is what I would prefer, but if we do that, then we'll be putting ourselves in a similar situation as I mentioned earlier, New York City and Italy, and Spain. So when the right time is, I don't know, but I don't think it's here yet. We have a one visitor policy at the Pearly for end of life. And so that person would come in and would be fully decked in PPE so that they could be there. And it's not ideal, but it's better than nobody there. So I don't know, it's a good question.
Yeah. One follow-up question I have for that, which I hope will be helpful for all of our participants, is that when you have sort of a family caregiver coming in, or even your frontline staff, PSWs and nurses, what have you done from the infection control point of view to help them don and doff the PPE? Is there a process in place where you have someone who watches them, or someone who ensures that they're doing it well and properly to protect themselves?
In our facility, we do we have a phone call with people in advance of their arrival. We've got, the doors are all secured, and then upon entrance, we'll go through some direct instruction and modeling as to how to put on that PPE.
Okay.
For us at the facility, anybody who has actively dying order set printed out, that list is given to the commissioner at the front door. So those people are the only non-essential visitors allowed in the facility. They already know where the unit is, so they go and the nurse shows them how to put stuff on and off. Doffing the PPE is probably the one that needs the most supervision.
Okay, thank you. So perhaps maybe one more sort of question, and there's a few questions actually around this issue of hospital transfer for patients, either requested by family members, and in particular there was one comment that I was struck by in the question and answer box, which elaborated on somebody working in a facility where a decision was made, it sounds like higher up, that if someone was COVID-19 positive, they would automatically go to an isolation unit in the hospital. Right, and basically they were kind of told, well, now you don't need to have that conversation because we already know if you're going to get COVID-19, you're not going to be in the long-term care facility. Any thoughts about that?
I'm disappointed.
Yeah, so am I. So am I. Yeah.
So I'm not exactly sure, but I do believe that there's some places that have organized isolation units locally. So, if that's the process that they put in place, then I understand sort of like the transfer. At the same time, I don't see how transferring would preclude any kind of goals of care conversation or any end of life approaches that could be taken in the long-term care home.
That's a good point, Benoît. I think part of this this question though relates to what the on-site resources would be. I mean, if you're down to one nurse caring for 80 people, or you don't have the other equipment or the space. I mean, for instance, there are still many homes that have shared rooms or shared bathrooms, for example. It may be necessary to reduce the risk for transmission. So it's not something we want to do, but it's still a possibility.
Well, I mean, that didn't come across to me the way the statement was said.
Yeah.
Of course, if a person, if a home is just struggling, like just imploding because of staff reductions due to COVID, then you do what's best for everybody.
Yeah.
Yeah. I think all of us in our different jurisdictions and different settings are really trying to conduct these very nimble risk assessments on the go, right? To kind of see, well, what's the best decision in this situation? Is it to transfer to hospital because of shortage of staff? Is it to actually keep here? Because, I mean, or like we know from the patient perspective, and especially if we think of individuals with dementia, it's often best for them to, be where they are and not be going to a new, facility which has day and night noise and change of care providers who don't know the tricks of how to get them to change their clothes and how to eat and so on. So it's a very challenging time at this time to balance, sort of infection control precautions, pre-existing staffing issues, which have gotten worse, and then sort of, what's best for the patient.
Yeah.
Yeah.
So we're juggling all these balls and we're not allowed to drop any.
Yeah. Yeah. I think to that point, we have to be, I hope we can show ourselves a little bit of kindness and compassion at this time. I know Sharon alluded to that, and I can't stress that enough, that like, I'm sure, the health workers in many of these facilities, especially the PSWs and nurses, do so much amazing work, just even on a regular basis. And they actually handle so much workload, so passionately. And as has already been mentioned, they're like a family for the patients that are there. And at this time, we can't give them enough credit. And we hope that obviously our system will give them more than credit, as this has been an issue now that's coming up, that people deserve obviously better pay and sort of benefits and, sick leave and so on. All right. So just some future steps that are important to think about, in this situation. I mean, as we sort of spoke about, it's sort of a big tragedy that we're seeing unfolding, in front of our eyes, across the nation in our nursing home facilities. But this may be something where we have to prepare for the long haul, and we don't know how this curve will kind of, go. And, it's very important for us to look after ourselves. There could be a second sort of peak of cases that may happen in the fall, and many people are talking about that. As Sharon alluded to, I mean, it could be 12 to 18 months before we see a vaccine. And, the average life expectancy in long-term care facilities is around that, sort of range as well. So this really, presents some particular challenges. I mean, like never before, I mean, it is raising the essential importance of palliative care in nursing homes. And we talked about that, where nursing home patients are often functionally impaired and sort of have events, life-limiting illness, usually non-malignant illness. And really, this should spur us all to move together as a community to provide high quality education and quality improvement around palliative care. So of course, we know that almost all long-term care facilities, or every long-term care facility, has some plan for end-of-life care and has some discussions around goals of care. So now is a time to build from that and see how we can improve these measures in the context of the COVID-19 pandemic and beyond. And we really hope that this webinar is just the beginning of sort of ways that we can all reach out to each other as a community and learn from each other. And, that's once again, as I said, one of the silver linings of this pandemic, where we're seeing all sorts of people coming together, to learn about palliative care, which is an essential sort of skill that everyone who is a health worker has to have. Everyone needs to know about the basics of a palliative care approach. And also, once again, we're seeing, ironically, this limelight on long-term care facilities due to the tragedy that's occurring. And we hope that, people will advocate for the patients and the health workers, starting now and continuing beyond, and really, really try to improve the quality of life of all of these residents and their families. So, in conclusion, I mean, we spoke about many of these things, and we hope that you have always realized the value of palliative care education as a health worker connected to long-term care facilities, and it's never been more important than now. And one of the critical parts of that is having good goals of care conversations, making sure that in the context of a pandemic that we have medications available, and also alternate medications available if our first or second line options are not there. Having an approach to manage symptoms, which for COVID-19 may most commonly include breathlessness, respiratory secretions, and delirium, and being able to try to work in a system which may have scarce resources already that may be getting worse. And that may involve sort of systems level advocacy and sort of breaking down these walls and barriers and collaborating with our colleagues that are working outside of long-term care facilities, who hopefully in many jurisdictions that need it are now stepping up and will continue to provide that connection. I encourage you all to, if you want, once again, some information around, palliative care for COVID-19, to go to that specific webinar, which is available, on our website. And once again, at this time is without charge. Wrapping up, thank you for staying over, everyone, almost everyone. We know everyone is very busy at this time, and it really shows, with the number of participants we had, how important palliative care is. We would definitely, appreciate your feedback, and you're going to receive a link, with respect to that as well. Thank you, everyone.
Thank you.